Hello, my name is Arjun Verma. I'm the lead developer and CAD drafter for the digital pathology team. And today I'll be joined remotely by Neha Jain and Olivia Kronick in order to present on our project. Olivia is now going to go into the background of our project.
Hello, my name is Olivia Kronick, and today I'll be talking about the background, research, and biomedical engineering related components of this project. So I'm going to go into the background of why we decided this was a unique need that we wanted to address. So I'm going to talk about oncologic diagnoses in underdeveloped regions. The target countries that we had in mind when picking this project were Haiti and Bolivia, and the global burden of disease was a result of inadequate medical care in some underdeveloped regions in these countries. Haiti is one of the Western Hemisphere's poorest countries, and as of 2018, Haiti only had 54 local pathologists to service a population of approximately 11 million citizens. So these patients were forced to personally transport their biopsy samples to the capital, where the majority of these pathologists were located, if they are from a more rural area, in order to receive a diagnosis. And this process was very complicated, could take weeks to months, and thus decreased the quality of care and was an extreme financial burden on many people, and continues to be. So we saw a need here, and we wanted to address this problem by creating a device that can accurately capture, process, and upload pathology slide images. So from our two different sides of the project, the first is the biomedical engineering components. We wanted to create an adapter to connect the microscope to a smartphone, and we had to make sure that this adapter would fit the most common microscopes we might find in these areas, in these clinics, and also the smartphone models that they would have in these target countries. On the CS side, the process was to code an app which can take and process images at a fixed rate. It needed to be compatible with Android phones and have a set time interval for image capture. And by integrating these two parts of the project and these developments as a team, we created a comprehensive approach to replacing whole slide imaging to have remote diagnoses, which will make pathology diagnoses in these countries much more accessible.
So I'm going to go ahead and jump right into the requirements that we needed to fulfill in order to do this project. First off being, how are we going to get an accurate whole slide image? So accurate whole slide images require an image of the entire slide in clear, defined quality in order for the pathologist to view and recognize potential abnormalities in tissue. We determined this after discussing with Dr. Troy Tenney and several other pathologists at the Emory School of Medicine that these slide images need to encapsulate the entire slide. They need to be very clear, and we also need to have a sharp contrast between the slide and the white background so that pathologists can view things like the splitting of nuclei and other very small detailed factors that could lead to cancer or any other type of abnormality or disease in the tissue. So in order to handle this, I took a combined approach of an image mosaic stitching algorithm as well as image filtering to create a clear and well-defined whole slide image from several smaller images taken from a microscope. On the right, you can see the product of this. It's the top section of an H&E melanoma slide that was given to us by the Emory School of Medicine, and it was taken using the digital pathology app and processing server. So I'm going to go into the first part of that entire process, which is the microscope adapter. So we designed it in Fusion 360 based off a combination of design features from existing phone and microscope adapters that we got on Amazon. The very right image is the model that we created, and we built it based off of measurements that another colleague of ours, Bailey and Olivia, took from the microscope. And I utilized those measurements to create the CAD model that you see on the right. And then I 3D printed it and implemented it using a small screw and some nuts in order to hook the microscope adapter to the microscope. As you can see, the small black clip on the bottom grabs onto the phone and slides up and down the rectangular slit that allows the phone camera to line up with the hole that connects to the microscope so that the phone camera can view into the microscope. And this is the actual app. So as you can see on the very left, you can log into the app. Then you can input fields such as the accession number of the slide, as well as the slide staining and the cancer type. And then the middle image is the most important part of the app. It's where you can take pictures of the cancer slides. So if this were a live demo of the app, then I'd be moving around the stage of the slide and the microscope so that you'd be taking images of different sections of the slide and slowly going up and down and side to side and taking images of every single part of the slide. Then the Review Images button lets you go over all those images and upload them. So this is another example of our app in action. As you can see on the right, it's in the Review Images section. I took a bunch of slide images and they were sent to our image processing server and stitched together. I implemented the app in Android Studio because in lower developed countries, mostly Android phones are available. And the app utilizes OpenCV to capture and crop microscope images. And it sends them to a server that I was running on my computer at that moment in time that uses the image mosaic stitching algorithm to combine the images into a whole slide. So that's just the top right corner of a slide on the screen, but we have taken whole slide images. And this is just looking a little deeper into the code. On the left, you can see the Python server code that stitches the images together. And on the right, you can see the Java code for the app. And going into how the stitching algorithm works a little bit more, as you can see, it takes 4 images like that. This is just a small example. And it uses something called SURF, which is speeded up robust features, to detect key points in the images. And based off of those key points, it can map images onto each other. So if they share like major parts, then they can map them together. That's how the OpenCV stitching algorithm works. But this puts a constraint on our product because it means that there has to be overlap among images when you're taking slides. So as you can see, those 4 images on the left have a lot of overlap, and that's why they can combine into the image on the right, which has also had a image processing and sharpening kernel applied to it. So that sharpening kernel makes the image clearer and more well-defined. Once the images are processed, they're uploaded to our MongoDB database, which is based off of Amazon Web Services. It's hosted on there. And as you can see, it contains relevant metadata about the image, such as the accession number and the stain type, as well as a timestamp to follow HIPAA guidelines. And once it's on the database, you can view it from a website that I built in React so that pathologists in the future can potentially provide comments and maybe even diagnoses to these images. As of now, it's comments because we're still in the research and development phase. So once cancer slide images are uploaded, you can see them on the right as under uncommented or commented. And if you click on one of those little rectangles, you get to here. So it shows you the whole slide image, and it also allows doctors to put in comments about the image. Like say that is an abnormal splitting of nuclei in the top right corner of the picture, you should go get that checked out. If you hit send comments, it'll send that to the original user of the person who took the slide because they logged in with their email, and it'll also post it so other doctors can see it. So this really connects everything together. The app allows you to take images that is cooked on there with the adapter, the processing server processes it, uploads it to the database, and the website allows people from all over the world to view that confidentially. So some of our future goals are in automation because as of now, it's very tedious to manually move the slide around and capture images. So I'm going to pass this off to Neha, who can talk about what she did with the automation.
Hi, I'm Neha Jen, and I'm presenting on the automation aspect of our device. Currently, we are reviewing 2 possible designs for automation. Option 1 sits on top of the microscope stage, and option 2 manipulates the microscope adjustments. Option 1 is an XY table operated by a pulley guide rail system. It is cheap to assemble and can be easily adjusted. If the device fits on top of the microscope stage, no additional calibrations are needed to be calculated or implemented in the device code. However, cons to this option are that not all microscope stages are the same size. Size adjustments are difficult and costly to implement, as well as calibrations which will be needed with these size adjustments. Option 2 manipulates the microscope's adjustment mechanism and attaches on the side of the microscope under the XY knobs and operates with 2 servo motors. One with a hollow shaft through which a support beam will be placed to support the top servo motor. Each servo motor is attached to an adjustable grip for each knob. This allows easy adjustment for different knob sizes and can fit any microscope stage regardless of size. Calibration will be required with this device, however, can be easily implemented, and this device should allow for higher implementation in image acquisition. Current cons to this device are the calibration is always going to be required for every installation. And also the parts for this device are more expensive than the parts for the XY table that sits on top of the microscope stage. Specifically, the hollow shaft servomotor. Option 2 currently does not have a prototype and is still in the design phase, while option 1 has initially been prototyped.
So we're focusing on that in the future, as well as other aspects of the app, such as a feedback that allows the user to view a fully stitched image so that they can make sure that it was uploaded properly. But we were very excited to work on this project, and we're very excited to work on it more. Thank you all so much for having us, and please let us know if you have any questions.
Good morning. My name is Ludi, and I'm a third-year general surgery resident at Emory. I'll be discussing my experience doing research in Santa Cruz, Bolivia from 2018 to 2020. Over the course of this presentation, I will introduce how I found the fellowship and share details on a few of the projects I worked on, including guidance for other trainees along the way. There are actually quite a few programs out there. Each one has a different structure. There are some embedded in residency as tracks, some purely clinical, only available after residency, some are policy-based, and others like the Bolivia Trauma Initiative are research and education-based. I chose the BTI because it was the right fit for me. I had majored in Spanish in college, and I had done some trauma registry-related research in Haiti during medical school, so to be able to continue the trauma-related research in a Spanish-speaking country was a win-win. Also, the majority of time for this fellowship is spent in-country, giving you direct contact with stakeholders. Along those lines, the key to success in many research fellowships is finding the right mentors and local partners who have familiarity with the country, field of work, and political context where you will be based. Dr. Fonini was my in-country mentor, and Dr. Swaroop from Northwestern was my US-based mentor. But the true success of the collaboration was based on great relationships formed with the local stakeholders across many institutions, including the state and municipal departments of health, the Bolivian Surgical Society, and medical directors and surgeons at multiple hospitals. Another element that contributed to the success of this program was the continuity of resident research fellows involved in the project. Aside from minor political disruptions and now COVID, we have managed to have an in-country fellow working on the projects in Bolivia for almost 6 years. I will now shift to focus on 3 of our main projects, and I'll start with the Trauma Registry, which was first implemented in 2015. This is a 75-item combination multiple choice and fill-in-the-blank tool provided by the Pan American Trauma Society. Training and manuals were provided on how to collect the data and upload it into an online system. And over the course of 3 years, we collected data on over 9,000 patients. However, there are many limitations and frustrations from our local partners noted when I arrived to continue work on the registry. For instance, they identified that it was double the work having to fill out the Trauma Registry form as well as their own medical record forms. They found that there was unreliable or unavailable internet and a lack of computer resources both in the statistics department and the emergency department. They found that they had delays uploading the information into the online system based on staffing shortages and resource limitations in both the ED and the statistics departments. They were frustrated by the slow online system in terms of loading data, and also when they tried to download reports, they found that data had been duplicated. And then finally, with staff turnover and resident turnover, there was a lack of recent and frequent trainings, which was a frustration. Based on this feedback, we made 3 major systematic improvements. For instance, we've created a standardized form that integrated the trauma registry into the clinical medical record, simplified the trauma registry to 25 items, and made it more multiple choice with the information on one page front and back. We also found a new online system called Kobo Toolbox, which is a free resource from the Harvard Humanitarian Initiative. This has simplified forms with 20 different question formats, an integrated mobile and tablet form with online and offline data collection, an ability to create mapping and statistic analyses online. Lastly, we received a significant amount of support from the government. A mandate was passed in December 2018, approving the updated form and its implementation in the hospitals. In May of 2019, we hosted a meeting with medical directors and ED directors to advise them on the mandate and solicit their feedback on the form. While many obstacles were then faced over the course of the next 9 months for actual implementation, the Department of Health buy-in was crucial to making the eventual implementation a success. The second major project we worked on was a layperson trauma first responder course. True Bolivia is a course formed from 2 precursors piloted in Chicago and Bolivia, and it was structured to provide didactic and practical information to laypersons on how to respond to trauma patients in the field in resource-poor areas. It's a didactic course that has information on trauma, statistics, methods of prevention, scene safety, personal safety, patient transfers, airway management, bleeding control, and pelvic binding. We also have 4 practical stations where they can practice transferring patients based on injury patterns, managing airway with jaw thrust and rescue position, providing bleeding control with direct pressure, cloth tourniquets, and combat tourniquet application, and finally controlling pelvic fracture hemorrhage with pelvic binder. At the end of the course, all participants who attended both days of the course receive a certificate signed by the Director of the Urban Mobility Sector of the municipal government, which is a very valuable asset for building participant confidence to assist with trauma injuries in the future. Over the 14 months, we provided 24 courses with almost 355 participants completing the entire course. We saw improvements in confidence before and after the course, as well as knowledge on a 9-question assessment from 33% to 68% after the course. After reporting the data back to the municipal government, we took participant feedback into consideration and introduced a partnership with a local urban rescue group. We now do the true didactic and practical session in 2 hours, and then we have 2 hours dedicated to CPR, choking management, as well as fire prevention and extinction. The last major project I'll discuss is a basic laparoscopic education course that we provided. We provided this course after working with surgeons and residents at the local hospitals and noting that they do laparoscopic cases, but the residents were frustrated by the lack of practice space for improving their skills. Therefore, we partnered with the Bolivian Surgical Society to bring trainers from Emory and teach a basic laparoscopic curriculum similar to the fundamentals of laparoscopic surgery course provided in the United States. We noted improvements in skills and confidence, and we received requests for additional training. And while the in-person courses were disrupted by the COVID pandemic, we were able to maintain a relationship and provide 2 courses virtually through collaboration with the local Pediatric Surgical Society, mainly facilitated by our partner, Dr. Lorena Jaregui. So with that brief summary, I wanted to thank the organizers of this panel for inviting me to speak, and I want to profusely thank the Emory Department of Surgery for their support during my fellowship, as well as the Northwestern Global Health Institute for funding me for the first year, and I would like to thank all the local stakeholders for their partnership during this fellowship time. Thank you so much.
Hey everyone, I'm Sam. I'm from Cleveland, Ohio. I came down to Atlanta about 10 years ago to start a college at Emory, and then I graduated, took a few years off, and now I'm back at Emory for medical school. I'm finishing up my 4th year, and I'm applying into orthopedic surgery. And my time in global health started while I was in college. We took a week-long trip to Honduras with a group called Global Medical Brigades. And what we did was we set up rural medicine clinics outside of Tegucigalpa. And we sort of dispensed medications, took vitals, basic medical advice, taught dental hygiene, that sort of thing, gave out supplies, nothing too crazy. And then I took some time off after college, came back for medical school, and these were surgical trips, general surgery, urology, pediatric surgery, oral maxillofacial surgery. And during my 2nd year, when we were scheduled to go to Haiti, the violence in Haiti caused us to divert to Puerto Rico. So I spent a week in Puerto Rico, which was not surgical. That was, again, kind of dispensing supplies, doing vital checks, that sort of thing. And then during my 3rd year, in the spring of my 3rd year, just before COVID hit, I went on an independent surgical mission to a place called Llantalo in Peru. And that was with a pediatric surgeon, Dr. Amina Bhatia, who's here at CHOA. And that was basically a pre-op clinic on a Sunday, followed by surgical days for the rest of the week. Though we had some difficulties when a hurricane came through, and some of our patients couldn't make it to the rural clinic. So between Honduras and Puerto Rico and Peru, those are the 3 main things that I've traveled to, but I've helped plan trips to both Haiti and Bolivia, which got canceled for various reasons, including COVID and violence in Haiti. So I'm happy to answer any questions. I'm happy to talk about how these trips have helped me in my application to residency. And so I'm looking forward to hearing what you all have to say.
Good morning. Thank you for the opportunity to speak here today. My name is Amit Pajari. A little about myself: I'm currently a first-year resident in the Division of Vascular Surgery at the University of Washington. I'm also an Atlanta native and a graduate of the 2020 class from the Emory University School of Medicine. I had the privilege of being a member of the 2018 Emory Haiti Alliance trip, of which unfortunately was the last opportunity that we had to physically be present in the country due to political unrest, as well as more recently the COVID pandemic. I'd like to take some time to share our experiences as medical students being a part of this trip, and finish with some of my own thoughts about global health and global surgery that I feel like I've gained via this, as well as some other experiences and in discussion with others who are passionate about global health. As you can see here, we visited the Hospital Bienfaisance in Pignon, Haiti. Over the course of the year preceding this trip, we had to work pretty tirelessly to coordinate our visit, as well as fundraise in order to finance our transportation, as well as procurement of all of the medical supplies and medications that we needed in order to run a preoperative clinic, as well as the operating room. Many of the patients had been informed about our arrival during the year leading up to the month that we were there, and brought with them some of their own images and laboratory studies, although we could do some of that ourselves at the hospital. Patients that were worked up in our preoperative clinic and deemed appropriate for surgery were scheduled for later during the week and presented into the pre-op area. As medical students, we were really involved in all aspects of perioperative care. When the patients first arrived, we had helped check them in, get initial set of vitals and IV access, and then go through a formal consent process in Haitian Creole in order to make sure the patients understood what they were about to undergo and that they consented to both the risks and the benefits of it. After patients were sufficiently checked in, we would physically walk with the patients back to the operating room, as you can see here, which really looks just like any OR that you would see in the US. Of note, all of the medical supplies that we used in the OR were brought down by our team from Atlanta, and it was entirely staffed by our team members from throughout the Emory system. Many patients underwent regional anesthesia, which we were able to assist in actually performing this under the direct supervision of our anesthesiology attendings and CRNAs. In the operating room, we functioned as first assist for cases such as open prostatectomies and inguinal hernia repairs, and really got to be immersed in the actual surgical care, but from beginning in the pre-op clinic all the way till the end in PACU. We did have access to laparoscopic equipment, and we're able to also use this as an opportunity for our surgical attendings to help better the clinical practice of some of the surgeons who worked at this hospital in using this equipment. We brought down an entire team of surgical attendings, residents, anesthesiology attendings, CRNAs, pre-op and PACU nurses, and medical students. In the PACU, as you can see here, we really relied heavily on our local contacts in also serving as translators in Haitian Creole, of which many of the patients exclusively spoke. But really, we also functioned as PACU nurses and staying with the patient that we had operated on as they woke up from anesthesia, checking on their vitals every 5, 10, then 15, 30 minutes, and then also writing the initial draft of the operative report, which we would then go over with the surgical attending to make sure it was complete and accurate. In total, we were able to help a lot of patients with surgical problems that many of them had been suffering for many years. And it truly was a rewarding experience from that perspective. All the medical supplies and medications that we brought down were stored in a room which we were able to organize, including the medications, which you can see here. We would round on our patients that had been admitted to the hospital every morning, just like we would in the US, and make any decisions that needed to be made regarding their care. Each patient had a chart for which we would write daily progress notes, and also included their medications that we were personally administering to the patient. In total, it was a really rewarding experience in the sense that it allowed us to get a full sense of what goes into taking care of a surgical patient, something that we don't really see as medical students in the healthcare system within the U.S. Based on our role and the roles of each member of the perioperative team. After this trip, as I mentioned earlier, we weren't able to return the following year, which was, again, very regrettable, as we had been performing this trip for upwards of 10 years. We did, however, pivot over the following year and work alongside one of the general surgeons at Emory to visit Puerto Rico, where she had been actively engaged in efforts within global health. And in our case, we were able to contribute to that by participating in a needs assessment, creating a mobile primary care team to visit rural and homeless patients in Puerto Rico, as well as deliver much needed medical supplies. Since transitioning to residency, I started to become involved in the University of Washington's Global and Rural Surgery program, where we've begun to discuss initiatives towards, being active in both our careers as residents as well as our future careers. My main takeaways from this regarding global health and global surgery are first, that your local on-the-ground partners are essential, both in making an initiative like this successful, as well as making these efforts legitimate. If you're not working with someone who's going to be able to be there and continue your efforts after you're gone, you likely shouldn't be there in the first place. I also encourage you to use the 50-50 rule. If, as a part of your efforts, you're engaging in academic research related to those efforts, it really put an effort towards having at least 50% of the academic products from this be first authored by your local partners. And sometimes this can involve a discussion because there are nuances to the nature of authorship. In some countries where being the last author on a paper could be considered the most senior and often a very important role in the US, it may not be perceived the same way in other cultures or parts of the world. And lastly, plan ahead as much as you can, but expect that things will change. That's the nature of global health and global surgery, is being flexible and being able to go with the flow in terms of dealing with anything that comes up. Thank you again for allowing me to participate in this panel, and for the people of Haiti and allowing me to learn from my experience there and be a very small part in providing surgical care to the population. Thank you.
Hello, everyone. We're just waiting a few minutes while we get all of the panelists back into the session here for question and answer. If you do have any questions, feel free to put them in the chat, and I will go ahead and ask them for you. Just waiting here to make sure everyone is here. I'm keeping an eye on the chat here just in case any questions come in. It seems like we have almost everyone, so I'll go ahead and kind of kick us off with a question. So I'm a little biased towards the Georgia Tech team since I went there, and I was really excited to kind of see your presentation. It's really awesome that you were able to do that work. So this is really for Arjun or Olivia or Neha, whichever one of you wants to answer, or for all of you. So your remote pathology team did pretty incredible work developing that product and the software solution to the problem of long turnaround times and poor utilization of pathology services in Haiti and Bolivia. So going beyond product development, how has your team approached the task of integrating this technology into a different cultural, economic, and value system in country? And in what ways have you had to rely on local partners to work through those sorts of challenges?
So that's something that we took a lot into account on our background research and what we looked into a lot last semester, like thinking about like how we could utilize the resources in countries like Haiti and Bolivia. That's mostly why we implemented it as an Android app and why we made like a really lightweight adapter so that we could do everything really cheaply and with the resources they had over there. So that consideration is what caused us to develop like the app idea in the first place.
Awesome. I do have a question here from Janavi. Forgive me if my pronunciation isn't quite right. It says, it's great to see a couple of the trainees who work with us in Haiti. Given the lack of political stability in Haiti that kept us from going back in the last few years, are you now concerned about the secondary impact of us no longer going there annually? What do you think is the best way to mitigate that possible harm? So I think that might be for Sam or Dr. Pujari.
Yes, certainly. And I think there are objective limitations to us being able to physically be there, but any other means that we should take. And one of the things that we did the year that we weren't able to go back was we were able to secure a donation of a gastroscope that we were able to give to the hospital that we weren't able to actually visit. And although we weren't able to physically be there, we were able to help support them. And unfortunately, I've not currently part of the Emory system. I don't know what's been going on since, but I think helping in any way that you can, no matter how small, and just showing them that you're still there, you're still their partner, even if you're not physically able to go during these times.
Great. I have a question.
I can add.
Go ahead.
Sorry, similarly, I went to Haiti as a student and then also have been involved with the Perioperative Alliance since then. But I think there's ways to communicate with them and let them know that we're still available, that we're interested in education projects. Like we did with Bolivia, there's ways to engage them and, offer either laparoscopic education, but I think the most important part is kind of reaching out to them and figuring out what their current needs are, how they've been affected by COVID. We have another project. We've worked on a COVID checklist. So we've talked about engaging our partners in Haiti and seeing, how the pandemic is affecting them, what sort of resources they need. Do they need more informational, educational resources or pamphlets? And we're excited to kind of re-engage them for that specific project. So I think if you're kind of touching base with them on a regular basis and kind of reassessing their needs, that would be a kind of a helpful way to at least stay engaged and support them from afar. But of course, the easiest and most reliable is to have someone in person and to be able to engage with people in person.
Okay, great. Thank you, guys. Sam, I have a question for you. So how do you feel a medical student is best able to provide value in both the surgical and non-surgical low resource setting? It's not uncommon in the US for patients to decline care from a medical student. Did you see any problems like that or difficult ethical situations with the surgical team or with yourself when it came to providing care overseas as a young trainee?
It's a good question. I don't think that there was there were none of those ethical issues. I don't think that culture of worrying about medical student involvement exists from the patient perspective in some of these more rural, underserved areas. But I think that the most important thing for being a younger trainee on these trips is that it may feel like the Wild West resource-wise, but it's not some playground for trainees to come and do more than they're comfortable with or do more than they ought to. So, when I was in Peru, I was able to kind of fill the med student role of gathering information, which you become good at over the first several years. But when I was in the OR, I was first assist, but I wasn't doing anything more than I was comfortable with or that the attending surgeon was comfortable with. So it's important that we don't cause any harm just because we're in a place that has fewer regulations or fewer trainees or fewer resources. So it's very much still a restricted scope of what you're able to do, but you are able to be helpful. And so I think just the most important thing is recognizing that you got to stay within your limits and your abilities, just as if you were in the United States.
Thanks. I have a question here. I think it really can apply to everyone. I'd love to hear from the Georgia Tech students as well. But as a student or trainee, how has your project shaped your aspirations for future endeavors, whether that's global surgery or health, with the Georgia Tech team, kind of where you're looking for your future careers, and how has it helped you pursue those aspirations? Whoever's comfortable can go first, but I'll call on the Georgia Tech people first, and then we'll go from there.
Sure. So like, I guess this was my first experience with like medical processing in the first place and like medical device development. And I had no idea that software played such a big role in it. So it was really interesting to kind of like dive deeper into this and do this project. And it definitely makes me interested to work on more medical device innovation in the future and like medical image processing and all that stuff, because I didn't realize how big of an impact software had on it.
I can speak to my own experience. I think the opportunities that I've tried to take advantage of throughout college and med school and some of the time in between, they're all sort of perspectives that I've tried to incorporate into my picture of what I want to do in my future career, which I think everyone here is still figuring out. And what I'm trying to do is use those to make sure I have a complete sense of how to do this responsibly. I think in every experience I've had so far, I learned something different about maybe things that I assumed were true that are not, and ways that I thought I was being helpful that I wasn't. And unfortunately, sometimes you don't realize it until after you get back or while you're there on the ground. But just using every opportunity to learn more about other people's perspectives, especially the perspective of the people that you're trying to work with and help, and make sure that whatever you do in the future is responsible and in the way it's being executed.
Great. I have a question from the audience here. So to any of the panelists, what opportunities would you recommend the School of Medicine provide you during your 4 years?
I can answer that. From a global health perspective, I think that it's hard for the School of Medicine to offer something for everybody, just because there's a lot of things that need to get done in 4 years. But what I really appreciated was a little bit of flexibility for them to allow me to identify time points when I could travel for some of these trips, and it would involve making things up later. But at least they were flexible and didn't absolutely say no. You have to be in Atlanta. You have to be doing this curriculum. So I think that in terms of opportunities, it doesn't necessarily need to be some blanket global health opportunities, but at least giving the flexibility to allow people to kind of pursue those aspirations if they're there.
One thing that I think could be helpful is, obviously there are opportunities because several of the people on this panel are a testament to that and have taken advantage of it, but it's not reasonable to expect everyone in the School of Medicine to take advantage of that for various reasons. But while we're in Puerto Rico or while we're in Haiti, there are often I often felt the sense of it wasn't so different from parts of rural Georgia, or really any part of rural America. And I think it would be very valuable if there was some sort of opportunity to, whether that be on a rotation, to practice in parts of rural Georgia. And I know that there is an option for it on the family or the primary care rotation, but very few people in the class actually get to partake in that. But if there was a way that more people or if everyone was obligated to spend some time in that setting to learn more about, because it's low resources in the same way that you're practicing when you're in Haiti or Bolivia or wherever else.
I would just echo those two comments that I think we do get a lot of great experience. with the OPEX's opportunities, and I think being able to offer us to be able to go and get those kind of local, because I think another thing about the Emory Haiti Alliance is that there's generally a few weeks or months of kind of different cultural competency type lectures that lead up to it, and I think a lot of the themes that we've been talking about in the symposium yesterday and today about kind of recognizing the local culture, the local partners, learning some of the language, all of those things are very helpful. But I think there's nothing that really replaces kind of being in person and being in a setting with lower resources and having to get creative sometimes with the supplies that you have, or kind of learn from them and see how they've been creative with what they have and how they can adjust and take care of patients. So I think you learn a lot from those experiences, and I would echo that. I think the discovery period gives us that 5 months of flexibility, and I think there's a lot of support from the School of Medicine when you find a mentor, when you find a project, to be able to kind of explore that and move forward with it. So I think there already is a lot of support from the School of Medicine, and I would encourage maybe if there's a way to kind of expand, again, some of those kind of cultural competency lectures that we have surrounding the Emory Haiti Alliance to more of the medical students, just to give them a general awareness of kind of respectful ways to interact with other cultures. It could be something to kind of integrate into the curriculum.
Great, thanks. Actually, Dr. Ludi, I have a question for you about your project. So in seeking to teach trauma and laparoscopic courses to local responders in Santa Cruz, what kind of impact did you see this service making in the community beyond your time there?
So I think I was really excited about the trauma, especially in particularly the layperson course, because initially we kind of started with our partners in the State Department of Health, and I think they have a lot on their plate managing kind of the whole entire state of Santa Cruz, and so and then we were able to kind of through another connection connect with the municipal government, which is again a kind of a smaller subset. They have a smaller precinct that they're helping take care of, and they have a Department of Transportation, and kind of in doing some of the Trauma Registry research, and maybe some of you tuned into Dr. Fuanini's talk yesterday, but they kind of recognize that there's a lot of motor vehicle collisions that happen in the city, and so we started to think about how this course could have the most impact while we were down there. And so in partnering with the Department of Transportation and kind of getting organized with the different transportation unions and the different taxi cab syndicates, we were able to really connect and kind of make an impact in the sense that we were able to deliver this course to people that we thought would be first responders at the scene of a collision. And I think we got a lot of great feedback from them in terms of feeling, especially with the practical component of the course, they felt, more comfortable moving a patient out of the street, or, trying to assess their airway and do a drop bust, or doing the pelvic binder. They felt like, these were tangible things that they could do. Now, there was kind of an interesting commentary that they don't really have a good Samaritan law in Bolivia or protection for bystanders as they're kind of coming across the scene of the accident. So there was a lot of nervousness and hesitancy that they would just immediately get pulled into the legal aspects surrounding the accident. And so I think in partnering with the municipal government, and I mentioned this in my talk, but getting the certificates that had the signature of the Secretary of the Department of Transportation, that gave them a little bit of backing and a little bit of confidence to be able to make an impact when they saw a collision. So and we're again, this has been a little bit interrupted, but we did 6 to 12 month follow-ups with participants and reached out to them and asked them, have you used these skills? Do you feel more confident? And we did a kind of a 12-month knowledge assessment, and they'd still had, great knowledge. They still had confidence. There were some of them that actually mentioned, witnessing an accident and being able to do a transfer or to assess their airway. And so, it was very rewarding to see that. And so I think, the hope, and I was kind of working on this transition when I was there, January, February, March, when COVID started, was to really starting this partnership with the urban rescue group and the firefighters to be able to add CPR, to add the fire extinction and prevention, but really we were kind of hoping to create kind of a local cadre of instructors for them to be able to kind of balloon out this course to more and more people. And so that process, that transfer, was just beginning to happen when this happened. But I think that would be one of my goals for the future, is to see us to be able to expand this course and who we offer it to. And then another kind of for the techies out there, we are working on developing an app where the taxi drivers or the police who respond to the collisions could log in the app what time, where, like factors that contributed to the collision, and then in the future we could create maps. So we have been able to kind of keep working on those types of projects from afar, and so that's kind of how we're hoping to analyze the impact. That there's going to be a question as part of that app that says, was any first aid provided? Was there any injury or death at the scene of the accident? So we're excited about that and the possibility of moving that forward.
Awesome, thank you. We have a couple of questions here that have come in the chat. So the first one is from Dr. Trainee Vasan. This is a question for everyone. There's a grim reality to having to fund your work in global efforts. Do you have any specific tips for individuals who want to pursue efforts longitudinally? What are the biggest barriers to funding?
I can briefly talk about that. I think some of the limitations to funding are that, some of the bigger grants from the NIH, Fogarty, are specific to countries. And so if you have an interest in doing and work in a country that it maybe isn't already supported by the Fogarty, it's a bit of a bear of a process to kind of create a new site. It's not impossible. And I think we're kind of going through that and applying for funding in Bolivia. Another thing is that they like to see kind of long-term commitment to a location, either by mentors or mentees. And so, I think we're, again, in Bolivia, starting to reach that 3-year mark of having Emory involvement. And so, it makes us a more attractive kind of candidate for funding and some of those bigger institutions. But I think funding is a challenge. There's other times you can kind of, especially like when I did kind of some research in Haiti, it was helpful to kind of look for smaller grants. So there's this Association of Tropical Hygiene and Medicine has some smaller, like $1,000, $1,500 travel grants and support for research. And so, there's organizations that have kind of very specific, themes that they will support. So you can, but sometimes it's helpful to kind of go for those smaller ones and kind of then build up to the amount of funding that you're looking for. Or looking for very targeted and doing it project-based, because the other thing is we did receive support for the laparoscopic course, kind of individual from the other projects in Bolivia. So it's kind of sometimes going project-specific is helpful as well.
Thank you. I'm going to go ahead and go to the next question just because I want to make sure we get everything in before we have to finish up in a few minutes. So a question from Henry Bierman. Question for the pathology team. What has the feedback been from users in country, and how does your team troubleshoot issues and provide real-time support in rural settings with this technology? So that's for the Georgia Tech team. Neha, I think you might be muted. I can't hear you.
Okay, sorry about that. Okay, so that is not something we've gotten to yet because we haven't actually tested with patients as of now. We're still in the steps of doing verification validation on our own before we start testing it on actual patients. So that is hopefully something we should get to by the summer, or like early this summer or by the end of the summer.
Yeah, as of now, we've only done like internal alpha testing with our own products and slides provided by Emory.
Awesome. I have a question from Hannah Millimet here. Dr. Ludi and Dr. Pujari, can you talk about the impact of your experiences in Haiti as you transition to starting residency? And I'll just go ahead and say we have about 5 more minutes for questions. So if anyone has anything, go ahead and drop them in the chat.
Yeah, sure. I can start. I think very directly, being in an operating room in another country, especially a lower income country, you at least I felt like I got a sense of how simple surgery can be sometimes, and that we often pull out these huge trays of equipment and tools for sometimes even a small surgery, and you realize how much waste can go into even some of the more commonplace surgeries that happen in the U.S. In terms of takeaways that I think have affected me in residency, it's paying attention to what's actually important in any case, and especially as I'm a very junior resident. It helped, at least for my own sake, get a sense of the whole process of surgery, because going down there, I got to see the preoperative clinic, when patients actually show up on the day of surgery, that aspect of it, and then sitting with them in PACU as they recovered from surgery, which again is not a role that we'll really ever have to personally do, but you appreciate the role of every individual that helps to take care of those operative patients. And then lastly, at least personally in residency, I think I've already found a community of people who have had similar experiences or related global health and global surgery experiences. And I think that community of people are sort of wired similarly. They like to think about the same kinds of things. They have similar aspirations for their future in terms of having some element of global health or global surgery in it. And I've felt or gotten a lot of satisfaction out of having just conversations with those people.
I would echo Dr. Pujari's comments that I think one of the kind of crucial elements of the Haiti trip is that we are kind of encouraged to take full responsibility for the patients. We do a call schedule overnight where we're checking on the patients at 2, 4, and 6 a.m. And, those are things that you're going to do in residency as well. You can't always rely on, the vitals or you get the report of the vitals and then you actually need to go and directly check on the patient. So I think it really encourages you to take ownership of the patients, and then certainly get the hands-on experience of being in the operating room and doing the pre and post-op clinic, so you get this kind of full sense and full spectrum. And I can still vividly remember a lot of the patients that we took care of in Haiti. And I think I would also echo that you get a true appreciation for trying to use the lowest number of resources possible and prevent waste. And so I would certainly echo those comments. And then for kind of a career and perspective, I think I enjoyed my 3 months in Haiti, the month of the surgery trip, and then staying down for 2 months of research. And I think it kind of inspired me to be motivated to use my research time in residency to make sure that I spent more time in a low resource setting to figure out is that how I want to structure my career, and do I like the education aspect and the research aspect that I was doing in Haiti. And so kind of using my research time to confirm that that's what I want to do. I want to be in country. I want to be incorporating research. I want to be incorporating education, in addition to my clinical experience or provision.
Wonderful. Thank you guys so much. That is all the time we have for questions. So thank you, Dr. Pujari, Dr. Ludi, Arjun, Olivia, Neha, and Sam for sticking around to answer any questions from the audience. And everyone stay tuned. Coming up, we have the poster session in a few minutes. And there's definitely some exciting posters coming on that. So thank you everyone again. And we'll be back in a few minutes.